All right, kia ora everyone. So it's my job to try and help you understand a little bit more about NETs. I know that today we probably have some experts in amongst you all, and this might just be very basic for you. But I also know that there might be some new people and people trying to still get their heads around what neuroendocrine tumours are. And so that's why we've decided to start the day with a little bit about NETs. And we'll go from there. Just bear with me. Sorry, my head is full of cold. So these are some of the things that I'll be going through step by step. I'm not going to go into too much detail on all the different treatments and tests. However, we can answer some of those if you have specific questions about treatments and tests. We can go through some of those in the Q&A session. We can direct the really tough questions to Ben and Veronica. So what are neuroendocrine tumours? Like any cancer, a cancer develops when some cells in your body start to divide and replicate and grow uncontrollably, and so they can develop a mass. But neuroendocrine cells are cells that have specialist functions in that they help control hormones and peptides in the body, and they help control organs or different organs as a result through those hormone secretions. And just to be different to other cancers, they are found throughout the body. So they don't come from one specific area in the body. Probably about, actually, I don't even want to guess. I was listening to a talk the other day, and someone was saying that actually lung NETs were the most prevalent. My experience, certainly in Auckland, is that we seem to have more gastrointestinal NETs. But it could be a good question for Ben and Veronica later as to which type of NETs are the most prevalent. And as you can see from this picture or this slide, we get gastrointestinal NETs, which can start in many different areas of the gastrointestinal system. We can get endocrine organs with neuroendocrine cells, where the neuroendocrine cancer can start. And then you get the other areas, like even in the skin or the appendix. And just next to all of those things, I've put other names. And unfortunately for neuroendocrine cancers, through history, they've been referred to by many different names. So when you hear medullary thyroid carcinoma, that's actually a neuroendocrine cancer. Or those are two really long words associated with the adrenal glands, pheochromocytomas and paragangliomas, again, neuroendocrine tumors, or Merkel cell associated with the skin. As I said, many neuroendocrine cells are responsible for causing or influencing hormone secretions in the body. And so as a result, a lot of people with neuroendocrine cancers can develop symptoms from their neuroendocrine cancer that are related to hormones. When they're related to hormone release, we quite often refer to them as functional neuroendocrine tumors, in that the hormones are thought to be causing the symptoms. You can see from this list of symptoms that they're very vague and broad and not very specific. You could argue you've been going in to see your GP for many, many years with diarrhea and being told that you've got irritable bowel syndrome before finally being diagnosed with a neuroendocrine tumor. And an international study or questionnaire survey was done quite a few years back now, and these are the results from that patients were often reported seeing over 10 health professionals before finally being diagnosed correctly, and it can take 5 to 7 years before getting that diagnosis. So it's quite a long time for some people to get diagnosed. As I mentioned before, we like to confuse things with the names, and neuroendocrine tumours. And
Okay, got it sorted now.
when we have a group of hormones causing, or a specific hormone causing a group of symptoms, we often refer to our neuroendocrine cancers by a different name. So if, for example, one of the more common ones, carcinoid syndrome, is something that you've heard referred to for your specific case, it probably means that you're getting diarrhea and flushing most commonly, and the hormone that's probably most involved with your cancer is the serotonin release. And it can be different for different people. We have insulin levels that can get affected, and then it might get referred to as an insulinoma. And so all of those names just indicate that the doctors are looking at specific hormones then, and those will be specific tests that they can then use to monitor your specific cancer. So you can see that neuroendocrine tumours are very broad, but then they can also be very narrow and very specific for different people. With most cancers, doctors look at that TNM staging, which is referring to where your tumours originated, how many nodes locally are involved, and then how many metastases you have as well. With neuroendocrine tumours, however, we know that from those questionnaires, quite often, or the majority of people are diagnosed with quite extensive disease. They've been diagnosed after having it for a very, very long time. And quite often, as a result, the disease has spread past the local developing site, the tumour site, and there might be multiple nodes involved and numerous metastases. And so more commonly, you'll see people with stage 4 cancers, or stage 4 neuroendocrine cancers. But we grade them slightly differently based on a Ki-67 and a mitotic count. Now that's something that's a little bit different. That was set up, let me go back to that, sorry. So the Ki-67 is something where the pathologists look under the microscope and look at the number of cells dividing at any one specific time. And if under the microscope they use special stains and markers, they're very scientific, but they can look and see how many neuroendocrine cells in a specific slide are actually dividing at that point in time, and it gives them a percentage or a grading. And if it's really low number of cells dividing, then we know that the Ki-67 is really low, and it can go right up to 100%. So that gives us a grade, and it tells us how fast the neuroendocrine cancer could possibly be growing. So you saw this carcinoid word before. It came from a German scientist back in 1907. He called all neuroendocrine cancers carcinoid tumours because they didn't actually look like they were growing very rapidly under the microscope, and they were thought to be cancer-like but not actually cancerous. But in 2010 that was changed, and they decided that actually they were cancerous, and they divided them into different grades. Now this slide's a little bit confusing. You can have near the right term, and this is where we're all wrong, and even I'm using the wrong terminology today. I'm calling them NETs when they could be, they should be called neuroendocrine neoplasms. And neuroendocrine neoplasms are actually separated into two different groups: the neuroendocrine tumours and the neuroendocrine carcinomas. The tumours are well differentiated, and what that means is that the cells, when they've divided, so when the pathologists can see them under the microscope, they've divided, and the cells still look well developed and formed, and they've just taken their time to develop, and they look very similar to what they came from. And when they're poorly differentiated, it means they've divided so rapidly that the cell is actually really messy, and the cell lining isn't very clear, and It's because they're growing a lot faster. So the original cell you couldn't really tell if it was a neuroendocrine cell or anything, except for by the staining that the pathologists use. So they're very poorly differentiated, and it means that they're growing a lot faster. So using the classifications with that key 67, along with the net versus the neck, the World Health Organization back in 2010 graded neuroendocrine tumors into grades 1, 2, and 3. And that's where this slide comes in. So we know grade 1 tumors are when the key 67 index is less than, it's 2% and less. And grade 2 tumors are slightly higher. That key 67 index is between 3 and 20%. And then the grade 3 tumors are ones that are showing under the microscope to have more than 20% of those cells dividing at that one point in time. Now, there is a little group in that grade 3 section, that 3B section on the slide there, 3A slide, sorry, the net G3s, where they can be well differentiated but growing quite rapidly. So you can see from this picture I stole from Dr. Lawrence, actually, and it was a picture of a carcinoid, or a gastric carcinoid, or is it a type 1 gastric carcinoid? And you can see there's all these different names that it can be referred to. And it's actually most commonly called now a type 1 gastric net, and it's a grade 1. So you can see even within the medical profession, there's lots of different terminology for these neuroendocrine tumors. And it's not something that we want you to get caught up on or get worried about. And if you have any questions about your specific cancer, I'm happy to have you email me at any point, and we can go through and break it down slowly from the information that you've received, and then find out what's the most important thing going forward for you. This is just a pictorial view of how I understand neuroendocrine tumors. So we have those grade 1s, and then the grade 2s and the grade 3s. And in that grade 3 section, we sometimes have some that are well differentiated still between that lightning bolt and down towards the grade 2. But you can see they can be quite broad. And in fact, neuroendocrine tumors can be some of the slowest growing cancers of all cancers, and some of the fastest of all growing cancers. And so as a result, it can be very hard for doctors to choose the right treatment for each person. And then there's not every person with a neuroendocrine tumor will be treated in the same way. And Michelle's shown me up, she's updated her slides. As she said, over 3,000 New Zealanders are living with NETs and requiring treatment at the moment. So onto the treatments and tests. We have some specific treatments and tests that are done. So as I mentioned before, we have specific hormone tests. So if people have known specific symptoms and we've picked up that it's because of a particular hormone that's involved with the neuroendocrine cells causing extra secretion, then those particular hormones, if they can be measured, will be measured and monitored on a regular basis. We have another test, the chromogranin A, or the urine test, the 5-HIAA. Those are more specific to serotonin production. And as I said before, carcinoid syndrome is one of the more common syndromes where people get diarrhea, flushing, and so those are the ones that you might hear being tested most often for your case. But they aren't 100% accurate, and they can be influenced by foods and medications. So doctors, while they might monitor them every few months or even less frequently, they also take the results within the actual context of what's happening for you. And then onto the scans. I'm sure most of you have heard about the gallium PET scan. The octreotide scan is an older version in that the picture that it produces isn't quite as good. And then the MIBG scan is one that we use mostly for those adrenal-based neuroendocrine tumors, the pheochromocytomas and paragangliomas. The gallium PET scan picks up where tumors are growing really, really, really slowly. So they're really good for the slow-growing neuroendocrine tumors. Then we have lots and lots of medical treatments. We have somatostatin analogs, which Michelle mentioned before. Somatostatin analogs are used when people have symptoms, so when they've got a functional neuroendocrine tumor, to try and help overcome some of those symptoms. So they work by attaching to the outside of neuroendocrine cells, and by attaching to the outside of the neuroendocrine cells, they actually turn off the cell from producing some of those hormones. And so in doing that, they help reduce some of those side effects that people can experience, like diarrhea and flushing. Then we have lots of chemotherapies. Chemotherapies are given more so to people with the grade 2 and grade 3 neuroendocrine tumors, because obviously chemotherapies work by targeting cell division. And so if cells are dividing quite rapidly, then chemotherapies are going to work really well in targeting those cells that are dividing rapidly. They aren't used so much in those areas of the lower grades, so Ki67s in the lower half of 2% and 3% and maybe even up to 5%. They'd be used less commonly in those areas because the cells aren't dividing as rapidly. And what will happen is we'll give you chemotherapy, they'll target all dividing cells in your body, and can actually cause side effects rather than be helpful in killing those dividing cells. There are some targeted therapies, but unfortunately there aren't very many that are, there are none that are funded in New Zealand. And you can certainly ask Ben Lawrence a bit more about those. And immunotherapies, again, aren't funded in New Zealand and would only be used in certain instances. Surgery, there's lots of different types of surgery, and surgeries are chosen for different reasons. You can have a liver surgery. You can have embolization, where they target the liver with by blocking off blood supply to a specific part of the liver to kill off that part of the liver. Maybe there's multiple metastases in one section of the liver. SIRT is when they block off the liver with little beads that actually have radiation in them. And again, that's not funded in New Zealand. Radiofrequency ablation is a targeted radiation treatment where they stick a needle through the skin into the liver and try and target certain areas in the liver with radiotherapy at the end of that needle. And then in some instances, patients might need to consider cardiac heart valve replacement surgery, which is a big one. And that's most commonly associated with people with carcinoid syndrome. And if you have carcinoid syndrome, don't panic. It doesn't mean you're going to need a carcinoid heart valve replacement. It just means that when the doctors are asking for echocardiograms or echo tests to check on your heart, that means they're monitoring things carefully and making sure that you aren't at risk of developing heart valve problems. And then, of course, we've got the famous PRRT treatment, which I won't go into now because I think I'm doing another talk very shortly about PRRT. So how do doctors choose what treatments to do for you at different times? And you can see there's lots of different treatments to choose from. And bearing in mind that all neuroendocrine tumors differ in size, location, symptoms, how fast they grow, and then the number of metastases, where those metastases are. And sometimes even metastases can grow at a different speed or rate to the original location or site. So treatments are chosen for a required goal. they need to be chosen to help control symptoms for pain relief, to help slow down the rate of growth of a particular area, particularly maybe, or to help reduce or debulk tumours. And obviously there's a number of people involved in the different treatments that can be provided. And so quite often it will require quite a lot of people having a discussion about a particular case if it's not obvious what treatment might be best for your particular case. And now I've got some time for questions.